in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to the show, everyone. This is Buck Joffrey with Sapio with Buck Joffrey. Today, my guest is Dr. Glen Jeffery. He's a pioneering researcher in the field of vision science and aging. He's a distinguished neuroscientist at the Institute of Ophthalmology, University College London, where he leads groundbreaking research on age-related eye conditions and innovative treatments to combat vision decline. His work has been a big contributor in our understanding of how light affects cellular health, particularly in the retina. His research on deep red light has shown remarkably good potential in improving vision in aging individuals and other longevity implications as well. Welcome to the show.
Thank you very much. It's a pleasure to be here.
Great. And we're sort of an interesting topic to talk about red light because it is in that area where, obviously you have shown there's a significant benefit in terms of real science here. But it is one of those areas that seems to be target of a lot of, products and sales in this multi-billion-dollar industry of longevity. So I'm interested in kind of separating fact from fiction. But why don't you start with this, Dr. Jeffery? Can you explain to our audience sort of the significance of red light as it, what exactly is red light? And specifically how you found that it interacts with the mitochondria to improve their energy production.
Yeah, well, I think a lot of the importance of red light is the red light we don't see. Our visual range goes from about 400 to 700 nanometers. 700 nanometers is when you start to get deeper red light. But beyond 700 nanometers that you don't see is the infrared range. Now, we've evolved under sunlight, and sunlight has got vast amounts of infrared in it. And our mitochondria that provide energy for cell function are actually quite sensitive to light. And they've evolved under red light. The problem that we face at the moment is that we now live in buildings, and these buildings are illuminated by LEDs. And LEDs don't produce any red light. Even warm LEDs don't produce very much red light. So our bodies are sitting here after 5 million years of evolution, having been outside in a lot of red light. And suddenly we're inside and we're not getting very much red light.
Right.
So the red light is important for mitochondria because mitochondria fundamentally are just batteries. They provide the body with energy. As you get older, battery runs down. As you get sick with a lot of diseases, some of them are specifically mitochondrial diseases, battery runs down. The thing that we didn't really appreciate was that longer wavelength light actually acts to recharge the battery. So we're facing a bit of a problem at the moment, and the problem is we're living indoors. We're not getting that long wavelength light, that deep red light, and so our mitochondria suffer. Now, mitochondria not only are terribly important in the fact that they regulate metabolism, but they regulate aging. So when the battery really runs down in the cell, the mitochondria puts its hand up and says, time to die.
Let's talk specifically, though, the role of, whether it's a 670 nanometer wavelength, basically these wavelengths of red light. What are they doing specifically to the mitochondria that helps them to do their job better?
Okay, so if we look at our mitochondria, one thing it does is it passes an electron along through a series of stages. And that end stage is a stage where you produce ATP. So the electron moves along, and when it reaches that final stage, it produces ATP, which is this enormous energy that we run on. We generate our own body weight in it every day. That final stage is absorbing long wavelength light. When it absorbs that long wavelength light, you can think about it as lubricating an engine. It
Mm.
actually increases the efficiency of that electron moving along the electron transport chain. So we've now got a fairly good idea of the mechanism of what's going on. What we didn't really appreciate was the validity of this in our modern society and its importance for our general health.
What about in terms of aging, though? I'm guessing because of its application that you have in various macular degeneration and things like that, that this is a problem more in the elderly than, say, in children. And why might that be?
Well, definitely the case is a problem for the elderly. I'm getting old, so I'm really interested in it.
Sure.
It's a problem because as we age, our batteries run down. We've simply got less energy. One of the main theories of aging is the mitochondrial theory of aging, and it simply says you run your energy down. Now, it's interesting because the analogy with the battery goes a little bit further. Your old car battery, the energy runs down, but it also starts to leak acid around the terminals.
Sure.
Your mitochondria does exactly the same. As it runs down, it produces something that drives inflammation, reactive oxygen species.
Mm-hmm.
And as we age, we produce less energy, we produce more reactive oxygen species. So it's actually a societal problem, and I think really it's a public health problem.
When I think about the mitochondrial health and various supplements, and we're generally talking about things like ubiquinol or there's urolithin A, all these types of things. In some regards, can you think of this type of therapy is analogous to those types of supplements?
Well, I suppose you can. The difference is the magnitude of the effect. The magnitude of the effect of red light is really very dramatic compared with the magnitude of those supplements. So if we shine red light and we measure the amount of extra energy that's being produced, it's fast, it's rapid, and it goes up very quickly. You can see it.
How do you
It's
measure
hard.
that?
We measure that in a number of ways. First of all, we can actually biopsy and look at the ATP in the tissue. But now we have optical methods where a mitochondria, when it works hard, it's a bit like you. When you run up the stairs, you vasodilate and you get a bit red. Mitochondria do the same. As they work hard, they change their color. Now, with some fairly advanced technology, what we can do is we can shine a light at them and look at the light that's reflected back and watch how they're changing color as they work hard. So we've got a really good actual handle on that. You can measure it biochemically. You can measure it with optical engineering techniques, or you can measure it directly. If you say to a fly, you're a really old fly, I'm giving you a burst of red light and I'm measuring how quickly you walk, you get a result.
Yeah.
So we do it biochemically, we can do it optically, and we can just ask how the organism improves.
Speaking of flies, your research sort of spans both the insect world and you've done some clinical things as well. Not necessarily animals, right? Not so much mice and that kind of thing. But tell us a little bit about the research, specifically animals, and then how that's related to some of the clinical trials that you've been involved with.
So you want to do large numbers, you eventually go down to a fly. And a mitochondria in a fly is very similar to a mitochondria in you and I. So look, what's the big question? The big question is, how do we live longer and how do we stay healthy as we age? I don't want to make 120 and be miserable and unhappy.
Sure.
So if we take old flies and we expose them to red light, quite simply, unambiguously, they live longer. Right? They don't live absolutely longer. What happens is a big chunk of the middle-aged deaths go. And we've done that also in actually a study I just loved. We've done it with bees. Again, big populations, you get exactly the same result. Now, you can't do that with mice very easily, laboratory mice, because laboratory mice can live up to 2 years. It's going to cost you a fortune. Can't do it with humans. But what you find in a fly, you find in a human normally. So I think that was the apex of our animal research.
Uh-huh. So in terms of flies, it sounds like what you found was analogous to saying you improved their health span, but not their lifespan. Is that
Well, we do improve the average lifespan,
right?
but I think the big punch is health span.
Right.
That's where we need to be.
Got it. And then how about in terms of clinical trials? Tell us what you're seeing there. What have
Okay,
you seen?
so I'll tell you a bad story first, which is, of
Okay.
course, we went straight in and we did a clinical trial for macular degeneration with red light,
Uh-huh.
and we were bitterly disappointed. We didn't get an effect. But the critical mistake we made was that we recruited patients
It's too
too
late.
far down the road.
That makes sense. I was going to say that
It's just too far. Now,
if they're blind
another
already,
group-
it's not going to help.
yeah.
Right.
Another group in the UK has replicated
Yeah.
that, doing a much better job. They've got a result, right? So macular degeneration has been slowed with red light. I'm very pleased it's done. We've moved off in two different directions. So we have a clinical trial running for a disease called retinitis pigmentosa. I can't tell you the results of that because I don't know them. As you know, they're very often barred until we get a full result. Where we also have, I must say, one of the best results in my life, and the one that really touched all of us, is mitochondrial children that have mitochondrial disease. Their mitochondria just physically cannot produce much ATP. And these kids, they are relatively immobile. Many of them die in their 20s through heart failure. And we've been treating some of these children, and in some of them, we've had very dramatic results. We originally said our metric was, how much can you open your eye? Because they don't have enough ATP to lift the eye muscles, lift the eyelid muscles. We got a result in that within 2 weeks. Kids generally improved quite a lot. When you treat with red light, after a period of time, it becomes systemic. Mitochondria talk to one another across the body. So we started to get improvements in mobility. Now, we can't do it with every child with mitochondrial disease, but we can do it with a significant number, and these kids have no alternative. If we take the red light away, or if they get sick for some reason, then we take a step back and the child tends to regress a little bit, but we just come back in. We come back in later and we can take them back again.
So let's talk about delivery. I'm thinking again of this as a supplement or a drug or something analogous to that. How do you, does it need to be delivered through the eyes, or can you deliver? I don't know exactly the, the physiology with the wavelengths, but does it matter where you deliver it to get the benefit?
Far less so than we thought. So obviously with the mitochondrial children, we were delivering it to the eye, and eventually their mobility improved. We've started delivering it. We work now quite a lot with architects and with lighting engineers and designers, and we're putting that lighting into buildings and we're getting improvements. So, to some extent, we're saturating people with that light. Some of these wavelengths are so long you can't see them, so people don't know they're there. When you ask the question about kind of delivery in different places, one of the key mitochondrial diseases is Parkinson's disease. Parkinson's disease starts because the mitochondria in a small little nucleus in your brainstem start to die. People have improved monkeys with Parkinson's disease with red light, and bizarrely, but we all know it's actually true, if you give the red light actually to the lower part of the body or to the legs, you eventually get an improvement, because mitochondria will improve, and then mitochondria in different parts of the body will all click in with that improvement. It sounds far-fetched, but in actual fact, a lady did a beautiful study published in Cell about 10 years ago, establishing the principle mitochondria talk to one another. So
they're also migratory to a certain extent, right?
Yes, they're migratory. Some people are arguing that they're found in blood. That's still out for debate. Some people are actually arguing that they unload cargoes. that they can move between cells. We've seen evidence for that as well. So we've got a very limited notion of what mitochondria can do. So we sit and think about them as generating energy. They do a
Right.
lot more than that.
So your thought is maybe, or the theory is that maybe there's some sort of, I don't know, some sort of cytokine release from various cells, that are ultimately traveling through the body and reaching other organ systems and muscles and that kind of thing, and potentially triggering the same response. Is that?
Yeah. So we measured cytokines. We looked at them between normal mice and mice that had red light, and there were very strange changes. You always think about cytokines as unpleasant things. You've got to drive them down. They're bad news.
Yeah.
But
Yeah.
That's not always true.
It's a signaling. Right.
It's a signaling mechanism. And the patterns of cytokine signaling were very different in mice that had red light. Now, we are now in the process of repeating that in humans. And we're looking at serum from people that had red light and not had red light. And we're scanning that for a wide range of agents.
So when you think about all of the other types of benefits, you have mitochondrial dysfunction is involved in a variety of other diseases. For example, your biggest reservoir for blood glucose is your muscles, who are highly reliant on mitochondria. So I believe you've shown some benefit actually in glucose metabolism. Can you talk a little bit about that?
Yeah, certainly. I mean, I think that was, if you think about science, you can think about things you've done scientifically and you're quite happy with them. You can also think about things, what's translated? What's translated? And this wasn't my idea. It was a colleague of mine. And he said to me, well, Glenn, if you're driving mitochondria harder, they need their own fuel. And their fuel is glucose from serum and oxygen that you breathe. And he said, well, if you drive mitochondria hard with red light, you should get a drop in serum, in glucose in the serum. And absolutely spot on. We took a group of healthy individuals. We gave them a glucose tolerance test, a horrible thing. We pricking your fingers, drinking vast amounts of horrible glucose, and watching how your blood glucose level goes up. We then took another group and we gave them a burst of red light to make their mitochondria hungrier. Then we gave them the glucose and it didn't go up to the same extent. In fact, it was significantly reduced.
Mm-hmm.
Okay, that's normal people, and they were academics and postdocs and things like that, so they were quite young. So we're now just finishing a study in type 2 diabetes, and we've got exactly the same effect. If we give you a burst of red light, your blood glucose does not peak in the same way. And I mean, it's not so much how high your blood glucose is, it's spiking you want to get rid of. It's the spiking that's dangerous. And the spiking is reduced time after time. And I think that is a very strong argument in terms of public health for changing your lighting and bringing some red light back into your environment.
So let's talk a little bit about that again, because if I think of, this intervention that you'd studied, what's sort of the dose response of red light? Would you have expected that, if you had given this red light a few hours earlier, it may not have had the same benefit of reducing blood sugar? Or do you have any sense of that? Like, obviously, again, looking at it analogous to some sort of any other intervention, what is the sort of the dosing or regularity that provides sort of any kind of optimal effect?
Difficult one, really difficult. Firstly, there's no obvious dose response curve. If I give you, 5 milliwatts per centimeter squared of energy compared with 30 milliwatts of per centimeter squared of energy, there's no difference in the effect. It's a switch. We're arguing about that. And that switch, I thought that switch lasted 5 days. I've been going around telling me 5 days, it'll last 5 days.
Yeah.
It certainly does last 5 days. But we're now doing a series of experiments in part of UCL where there's no daylight. And we've gone in and we've taken out all the LED lights and we put in old incandescent lights, hot ones, that I think America's about to ban, and we're going to ban them as well, because they produced a large amount of infrared. Now, we left them in, actually, it was a bunch of architectural technicians. We left the lights there, took them away after 2 weeks. Now, I was expecting 5 days later for our metric was their ability to see color. 2 weeks later, they were still up.
Yeah.
Now, this morning is another 2 weeks further down the road, and most of them are still better than their baseline.
Yeah.
So we do know it's a switch, maybe the release of an enzyme. We do know now that it lasts quite a long period of time. So maybe you only need a burst of light, at intervals in your life. Not
So
quite
some
sure.
sort of minimal effective dose. I mean, I know, like, it looks like you've used sort of the 3-minute mark in some of the things you've written about. Is that right?
Yeah, 3 minutes. Well, we say 3 minutes because a lot of the time we're working with elderly people. Now, the critical temporal sort of window is really a minute and a half. But if I say that to a group of older people, some of them are going to do a minute. Some of them are going to undershoot. So we say 3 minutes, right? That's the safe kind of thing. But you can get a pretty full effect at 1.5 minutes. And we had a master's student do a great project with us on looking at a perception of color with red light. And we set all her devices at, I think, about 8 milliwatts per centimeter squared. And we came back and we found it was wrong. They were delivering 1 milliwatt per centimeter. Now that's dim. And it was having an effect. I think the key thing is when you deliver the red light, there are no other wavelengths of light present in that experiment, because blue light, short wavelength light present in LEDs, is having the opposite effect of the mitochondria. So if we can take that negative effect away, perhaps we can highlight the effect of a small red dose.
What about natural daylight? Like, is there an appropriate dose or a therapeutic dose in simply going outside in the morning for 3 minutes?
Yeah. Well, I don't know about 3 minutes. There's a whole range of epidemiological studies that show that people that spend more time outside in daylight have got a whole range of, their regulation of their insulin regulation is much better.
Sure.
There's a much lower rate of diabetes. There's actually lower rates of cancer. You've evolved outside. That's where you really fundamentally should be.
So, and I get that. I guess the question is there an additional benefit to a specific red light, a very narrow exposure of red light as opposed to daylight? Is there an additional benefit, and how do we know that?
I think I use the analogy that I've got one of the world's best sticking plasters for a problem. You've got a problem. I can get rid of some problems. I can hold some problems at bay with a burst of 670 or 850 nanometer light. But ultimately, I think the issue is spending a lot more time outside, because I'm giving you this little sort of narrow beam of light in terms of the spectra, whereas out there you're getting a vast range of infrared, and we've not pulled all this apart. It's a vast job. But I always say to everybody, why don't you try and spend an hour or 2 hours a day outside? Even on a cloudy day, the infrared light is scattered, but it's not stopped by clouds.
Yeah. And obviously, wearing a hat and making sure you don't get burned at the same time is wise too. What about sunglasses in that situation? Are you minimizing, minimizing the effect of wavelengths? I guess I just don't know the physics very well. So.
Okay. So the long wavelength light, once you go above 700 nanometers, it goes through most things. It'll go through clothes. It'll go through 800 nanometers, goes straight through bone. So, there's some photographs out there that we took for architectural magazines of people's hands on an 850 light source. You can't see the bone. The light streams through. You can't see the bone. So blocking those long wavelengths. You can't do it with clothes unless you want to wear a scuba outfit of rubber. You can't block it, and it's going to go deep into your body.
Is there some potential downside? I mean, one of the things that comes to mind for me is what you're really talking about is really increasing or improving metabolic function. And so if you have a highly metabolic cellular process, like, like for example, brain tumors, glioblastoma multiforme, for example, is highly metabolic. Do you worry about, exposure to people for things like that?
Yeah, we had that as exclusion criteria. We had cancer or proliferative diseases as an exclusion criteria for our clinical trials. If you take normal cells and you give them red light, they've got a tendency to proliferate. Now, we were pretty adamant about that. 3 weeks ago, I examined a fantastic PhD in London from a student who'd taken lung tissue and cancerous lung tissue, same for kidney, same for liver, and she treated both of them with red light. Yeah. And the interesting thing was, in the normal tissue, it tended to increase the rate of proliferation. In the cancerous tissue, it pulled cells out of the cell cycle. Now, this needs a lot more work, and I'm still going to keep that as an exclusion criteria in the patient population. No one with cancer goes into the trial, but I'm extremely hopeful.
Yeah, but in theory, what you're saying is you're actually killing cancer cells, or you are inducing apoptosis in those cancer cells? Is that
no? It was just pulling them out of the cell cycle.
Pulling them out.
So they weren't dying, but they were stopping from proliferating.
I see. Okay, got
it. That's a good first step if you've got cancer.
Yeah.
Just stop it.
Sure. How about in terms of timing? When I think about our natural propensity for when you get red light, it's during the day. So, I mean, do you see any reason to have these exposures, therapeutic exposures at various times of the day that are in line with that circadian rhythm, or does it not make a difference?
Definitely. Yeah. If we go back 10 years, there were a whole group of people working on red light, and they were getting different results. And we all met at an ophthalmology meeting in Baltimore, and we all sat there in a restaurant saying, why can't you replicate mine? Why can't I replicate yours? And it was only at the end of that meal that someone said, well, what time of day are you doing it? Yeah. And then suddenly we found that everyone who was doing their experiments in the afternoon were getting very minor results. Those people that are doing their experiments in the morning were getting great results. Now, that's been pulled apart now. So when you wake up in the morning, your body is in a very, very different state. Your mitochondria are working very hard. Your blood sugars are going up. Your hormones are all different. And the reason is you've been asleep for a number of hours and a predator could have been watching you. You need to wake up fast, get on your feet and move. When mitochondria are very active producing ATP, you can accelerate them. You can push them. When mitochondria in the afternoon are not producing so much ATP, you can't do anything with them. And my argument has always been we don't understand everything that mitochondria do. And in the afternoon, they're doing the ironing. They're doing the maintenance at the house. They're doing the dishes. They're not interested in light in the afternoon. Yeah. So experiments with red light don't work very well in the afternoon or at night. They kick off about 20 minutes before perceived dawn, before you think dawn's going to occur.
Got it. So let's talk about from a practical standpoint. Say somebody's listening to this, and myself included. In fact, I had recently just a random sort of partial retinal tear, and so I'm listening to this, and I'm like, oh gosh, that was about 4 months ago, and maybe it would be beneficial for me to get exposure to red light. Now, you can go on Amazon or something like that and just search them, but who knows what you're going to get, right? So practically speaking, how would you suggest someone who is interested in exploring this actually find a device that would provide them with real real wavelength and real,
Yeah.
possibility of
Yeah.
exploring if it works for them.
Yeah. Terribly important point. If you go on Amazon, you're going to find a vast number of devices. Now, most of those are extremely poor quality. We did start pulling them apart at one point, and then we just had to stop. I mean, these devices, sometimes you switched them on, they got hot and there was a smell and they never worked again. And you're thinking, do I want to put that in front of my eye? The answer was definitely not. But at the same time, I think it's important for us as a research group to have integrity. And so we have no commercial interest whatsoever.
Sure.
We have tested a few devices. Because you're going to come and ask me this question, and I have to be able to say to you, there's something out there.
Yeah, it's all right.
So we tested devices made, I think, by a company that now calls itself Light, Power and Health. We tested them because we use them, and we use them clinically. They're fine. We did have another company in Australia, and sadly, the gentleman that was running the company decided he wanted to retire. And that was a pity because I was also using his devices in clinical trials. So that one company
Light, Power and Health.
does make okay devices. I perhaps think they're more expensive.
What do you use? What do you use in your lab? I mean, are these these laboratory grade things that you can't get as an individual, or?
Yeah, we started off by making our own, but of course that's not going to work for you, is it?
Yeah.
So the important thing there is that I can say there is this company, we've used them. I cannot believe the number of companies that are walking through my door saying to me, "Will you recommend our device?" And the answer is no. Right? Absolutely not. Because I can't test all these devices. And for me to get ethics for this, I've got to walk through, my research is associated with Moorfields Eye Hospital, very big eye hospital. I've got to walk in there and say, I know this device is safe to get ethical permission.
So when you're shopping for a device like that, are you typically looking for like a pair of glasses or something, or are you looking at something that emanates light into that you stare at, or something that you apply to your skin?
My first reaction is, okay, you got one pair of eyes. Be really careful. Don't stick stuff in front of your eyes if you don't know what you're doing. You can do what I do, and that is I get up in the morning and I go down the kitchen, and you spend that 20 minutes in the kitchen doing stuff that basically think, what was I really doing in the kitchen this morning? And there we have I've got a large 670 lamp, which you can get from that company. I bounce it off the wall. And if I don't do that, then I do that when I come to work and I get changed in my office out of my cycling gear. I just bounce the light off the wall. Infrared light scatters everywhere. Absolutely, you can't see it, but it's scattering everywhere.
So you don't have to stare at it. You're in a room with it.
At one point, I will stick my neck out on saying, I know, if you buy something, particularly from the Far East, if you buy something, I don't care what they say, never stare at it.
Yeah, stare
never.
At it. Yeah.
Yeah, there's no quality control here. Absolutely none.
Glenn, do you notice any difference yourself subjectively, or are you just kind of trusting that it's doing what you're seeing in your research?
Well, it certainly did great things for my blood sugars.
Did it?
Yeah. Oh yeah. I was pre-diabetic, and my pre-diabetes is gone. All right.
Okay.
And I'm getting, not only is that research we do, I'm getting lots of comments from people about that.
And your regimen is, again, basically just turning on a 670 lamp for a few minutes a day. That's it.
That's pretty much it. Now, when we do a lot of our stuff on vision, so we're testing people's color vision, and we get big improvements in people's ability to differentiate colors. Most of them never come back and say, hey, my world has taken off in terms of color. But the problem that we have there is very often if you change the signal in the retina, the brain recorrects it. It resets it. So a good example of that is glaucoma. If you've got glaucoma, you lose large amounts of your peripheral vision, right? Lots of it's gone. When do you notice it? You notice it when you bump into the coffee table because you didn't see it. It's not that you've noticed that loss of vision. And the other really great one there is if you've got a cataract. Okay, when the surgeon takes your cataract out, surgeons love doing that experiment, doing that operation. You go, wow.
Yeah.
They put a clear lens in and you go, wow, isn't the world bright and clear and all the colors are great? You ask them 3 days later, that's all gone. The brain has reset that message.
Yeah.
It's reset things. So I can pull it apart. I can find it in my experiments. I can see it there. But not everybody gets a reaction to it, I'm afraid.
When you're doing these on retina patients in these clinical trials, how are you applying it there? I mean, are there specific devices that you're using on those people?
Yeah.
Or?
So in those cases, we were using very small torches, and this said particularly in the kids that we've got mitochondrial disease, very small torches that we did massive quality control on. And they came from the company in Australia, which I'm very sad to say isn't in business.
Yeah.
But the glasses that are made by Light Power Health, they do exactly the same.
Yeah. Fantastic. Well, fascinating stuff. Obviously, it's a really good information to know. I mean, I guess, the other part of this is, I think you mentioned, there's just so much, there's so much garbage out there right now trying to take advantage of any sort of research. And so it's also good to get your thoughts on that as well. So we do very much appreciate your time. And thank you very much for being on the program.
Once I make a stupid comment every time, if you didn't get the message about the company or you're worried about something, I set aside Sundays for answering people's emails.
Oh, is that right? And what's your email, Glenn?
You can find it on the web, g.jeffrey@ucl.ac.uk. My kids will kill me for telling you that, but it's important to deal with people's concerns.
That's great. I appreciate that. Don't be surprised getting an email from me.
Great.
All right.
Thank you very much.
Take care.
Thanks for listening to Sapio with Buck Joffrey. A quick reminder that while I am, in fact, a surgeon, nothing I say should be construed as medical advice. Now, make sure to include your physician in any medical decisions you make. And also, if you're enjoying the show, please make sure to show your support with a like, share, or subscribe. Until next time, this is Buck Joffrey for Sapio with Buck Joffrey.